Thank you. So the first session, the morning people, be very generous enough to alter the set the pace for the whole day. Anyways, yes. So yeah, not as a buzzword, not as a PowerPoint metric, and not just as a culture. We see health equity as a leadership attribute in here, having senior industry people and CEO and founders of organizations. So here we have three extraordinary voices with us, representing the psychological lens, the clinical quality lens, and the pharmaceutical access lens when it comes to health equity. Three different worlds, but one shared mission: fair, dignified, and accessible care for every human being out there. So let's make this session very honest, humane, and for every human being out there. Hopefully it creates much bigger impact and difference out there. So before we dive in, I'd love to introduce each of them, but let them do it by themselves so it'll have more emotion to whatever they do. So I will start with Mr. Ahmed Ezildin, who is the Senior Director of Newbridge Pharmaceuticals.
Thank you so much. My name is Ahmed Ez. I'm a Senior Director, Group Therapy Area in Newbridge Pharmaceuticals. Newbridge Pharmaceuticals is a contributor to health equity in a way or another. We are one-stop partner for multinational pharmaceutical companies who do not have access to the Middle East, and we are bringing their innovations here. And nice to meet you all.
Thank you, Ahmed. I understand that you are such a senior pharma leader working into bringing advanced therapies into real-world access. Thank you. And moving on to Claudia.
Hi, everybody. My name is Claudia. It's not working. It's not. Okay. Okay. Say it again. 1, 2, 1, 2, 1, 2. Okay. No. We change. Hello, my name is Claudia Schwinghammer from Austria, from Europe. I'm the founder and CEO of Spark, and we are a mental health company for corporates. So we make sure that everybody in the company has the right position to grow in their own tempo, and we make sure that there are results based on what people really want to support their growth.
So yes, thank you, Claudia. So we understand that you are a psychotherapist, deeply rooted in emotional safety and mental health of people.
Exactly.
Next, Dr. Pranita Rao, please, we'd love to hear from you.
Yeah. Myself, Dr. Pranita Rao. I work as Deputy Director for Quality and Patient Safety for Burjil Holdings. So I've been working in field of quality patient safety for almost 14 years. So we align with the clinical governance policies that speaks about the equity. I'm pretty excited to be here talking about the healthcare equity. Thank you.
So yes, we understand that you are a leader in quality and patient safety at Burjil Holdings. Yeah, perfect. So thank you so much all for your powerful introduction, setting the pace and the rhythm for the session. So I personally feel to understand health equity, we must go beyond systems into human behavior, organization structure, the culture, and the access barriers. So let's explore how each of it impact health equity for every class of life, people living around the world, not just one particular sector. So let's have a path. I just want to begin with Claudia because human mind, human behavior shapes every outcome in healthcare. Mm-hmm. So you understand human behavior deeply and just want to know, where do you actually find a mismatch between how healthcare systems are designed and how humans actually behave for it?
All right, thank you for the question. So, where I come from, it takes you between 3 to 9 months to get an opportunity to see a psychotherapist, no matter how good or bad you are. And that was the reason why I felt we should change something here. Because you might know it from your family, from your friends. If you feel mentally exhausted, if you suffer from depression, anxiety, whatever, you don't have the time to wait 9 months. So what we did is we offer a service that the corporates, so the leaders, the CEOs of the companies can, give their employees, their people a service that they get the access sooner, which is pretty critical. Because when you hurt yourself, when you broke your leg, you need to get treatment right away. Within mental health, it was a different story in my country, and that's let's say that's my why, and that's why I feel it's so important to really offer services for everybody who needs it.
Thank you for that. Now, maybe from human behavior, I would like to move to quality, clinical, and structural side of equity that we all want to know about. So just to know, Dr. Pranita, how do you define health equity in the context of hospital quality management?
See, this is a very interesting question. As I said, the healthcare equity it's not been treated as an isolated program. It is within the quality program as much as it speaks about safety and effectiveness. So healthcare equity is defined in the quality is like access to the quality programs, like having highest level of healthcare irrespective of the demographics, be it as a age, gender, races. So to have a same outcome when it irrespective of the population. So this is what we have in healthcare equity when it is speaking about the healthcare management.
Thank you so much, Dr. Pranita. You've given a better, more clarity how standards work into real-time, accessibility of healthcare. So now I want to bring in the pharmaceutical perspective into it, Mr. Ahmed. So because access of medication, advanced therapies, and technology is where the affordability criteria comes in, and where we personally feel the equity breaks down. So what are your thoughts on that?
Well, it's not the pharmaceutical companies' responsibility alone, but yes, pharmaceutical companies work together with the ecosystem to shape the access. And that's actually reflected in several ways. The pricing itself is a kind of equity service that we provide to healthcare systems with partnerships with ministries of health, with partnerships with regulatory bodies, where there is an FDA, for example, in the Saudi FDA, Jordanian FDA, the Ministry of Health in Egypt. So yes, we start with accessing the formularies. We start thinking of how we can price the products, not undermining the R&D cost there, but also considering the unreachable segments. And considering the unreachable segments, we are here talking about the disproportionate segments, special groups who are unaffordable, who are unaffording the medication. So yes, we design access programs, we design budget impact models, and some parts of the patient access programs could be leveraged up to making a study in a country where the country itself couldn't afford. So this way we hit double objectives. The first objective of which is to establish the access, and the second of which is to continue a long-term study, not affordability, but safety and long-term efficacy study after the product has been approved by the global authorities. So this way we make a bigger population accessible to treatment in an affordable way.
Thank you so much. So just want to know, deep dive into further of your personal experiences each. So Claudia, I just want to begin with you. So do you have any real-time example where really you feel that, that's the most important example or real-time thing that you literally saw in front of your eyes change because of the impact that you created?
Well, yes, we see that every day. And I have to tell you, I do the best job. If I could choose it again, I would do it again, because we really see people grow. And what we focus on are limiting beliefs, and everybody has these limiting beliefs, everybody. We sometimes believe we're not enough, and this, or we don't belong, or we're different, and these limiting beliefs really hinder us to be the best version of ourselves. And what I love to see is if people really grow out of their inner peace, and if they really feel like, oh wow, I can do it. I mean, I can sit there on stage and just talk about my feelings or what I would like to share with anybody. So this is what we get as a feedback, that people really feel released from these limiting beliefs they really carry like a big bag.
I want to go back to Mr. Ahmed. Do you have, and being a senior leader in the pharma industry, any small incident that you would keep it close to your heart, which you literally saw something transformative?
Actually, in the pharmaceutical industry, I think it's a double responsibility. As long as we are providing health equity in the ecosystem and in the countries, we should provide the health equity internally as leaders and put it as KPIs, especially to managers of people. And actually, health equity here doesn't mainly and necessitates that it's just mental health. It's a very important element, but also physical health, and considering several things, considering yes, physical health in travel and commuting time. We have a lot of field force members who should be considered in their physical health in their certain coverage of areas to do the sales. Physical health in the work time they spend. There are some laws that govern this, of course, labor laws, but actually considering this and rewarding this physical effort immensely should be in the KPIs of leaders. Other health is just like behavioral health. Do we recognize working hours? Do we recognize flexibility in working? Do we recognize different time zones for people who are working internationally? This is a kind of preserving the health as well and providing health equity. People who are not able to work from office, do we provide them with working from home options? So all this contributes. Yes, there are some basic fundamentals to health equity, like covering people with insurance, medical insurance to them and their family. These are fundamental, but also providing better tiers that covers certain patients and certain diseases, like rare disease. Not usually the medical insurance is covering this. So as leaders, we need to put, if it's not already put in place, but even to quantify this in the KPIs of leaders and have it in the DNA, as long as they are implementing it externally, it's good also to implement it internally.
Okay, thank you for that. So, Dr. Pranita, I just want to know, from your perspective, what do you think is the leadership role when it comes to embedding health equity into an organizational structure?
See, I have a very favorite quote when it comes to leadership. This leadership sets the tone of an organization. So embedding the health equity within the organization, it is not only defined in the policy standards, having one size fits for all kind of mindset. I would like to add on what Ahmed said. So it's about catering the needs. It's a tailoring the care needs. Having, for example, having educational paper catered in different language. As we know, Dubai is an expat country. It comes from people come from different communities, different background. And we do have patients who are not very strong with the literacy and not where they have a culture barriers or the language barriers. So having the same protocol will not get the same outcome out of that patient. So you need to have something extra for that patient. That is what we define in our standards. That's what the leadership has to look at it, to have healthcare equity counted in their vision, mission, and also in the strategies. And keeping the KPI has a transparent data to add as a KPI has a mission to measurable elements. So for us, when we talk about quality, we always talk about data-driven decisions. We talk about measurement data. So we can have those KPIs. We'll keep it very transparent, be it is patient experience data. So look at it, cut the the experience data into different demographics to identify the gaps. So this is where the leadership plays a very pivotal role when it comes to implementing the healthcare equity in an organization.
Thank you for that. Now, this question is to all three of you, right? So, yeah, I just want to know, being leaders, of course, leaders don't come overnight. You would have crossed every phase in an organization to become a leader today. What is that one blind spot which nobody often talks about when it comes to health equity? Anybody can take the question first.
Ladies first.
Then it would...
Okay, let me just start with that because it's a very interesting one. I feel the blind spot has come me when it comes to how I look at it is, as I said in my previous, one size fits for all. The leaders thinking that providing an equal care or having a standard protocol is what you speak about healthcare equity. Healthcare giving the equal treatment doesn't equals healthcare equity. Equity is tailored needs for each patient. So that is where I find it as a barrier or the bias which goes behind the healthcare leaders.
True, I can resonate with it when generally this can be put across, apart from health as well. Equity and equality always comes face to face, and somewhere everybody talks about equality, but then equity gets missed in the whole process. in everything that I would, anything that you can term it. So yes, Claudia.
Okay, so I would start with walk the talk, which means leaders should be aware how they are perceived from their employees. And what we do quite often within our company is we work on the issue of psychological safety. We heard that, I think it was yesterday or the day before, how important it is to grow. So we need psychological safety to grow. And what I get from the training sometimes is that leaders say, hey, why do my employees do not come? My door is open. It's like you can come anywhere. They don't come to me, speak up, tell me what's wrong in the company. And they wonder why nobody is coming. And I think we should change the perspective in a way that, okay, what did I do? How do I, how am I as a leader that people do not dare to open the door and talk with me? So this kind of perspective is something like, okay, I got it. So that could be the reason. So what is my energy as a leader that people do not dare to approach, to ask, to share if they don't feel good or uncertain?
Yes.
I had to answer now.
Yes.
Okay.
That happens when 3 women and 1 man sits in the panel.
Actually, I regret this now because actually you took my thoughts, but I'm happy that it's being echoed here. We started to see in many squads of sports teams, psychologists who are open to hear from players, from the technical team, from managers, and from the coach, that they talk without any barriers. They don't have stigmas. So they say what they like and what they don't like about the team, about the performance. In corporates, I'm not sure it's implemented everywhere. I'm not sure it's whether well implemented or not well structured. I think having a psychologist in every corporate, in every business, who is just dedicated to internal stigmas, where people come and say, I'm not comfortable with this. It's good to have it in the leader, Claudia, yes, but it's even better to have it like an external organization, like a third-party one, because actually there are also some stigmas internally within the organization. Some people are afraid to talk about their mental issues and physical issues in the stigmas when it comes to the disease, in order not to be positioned or cornered or even fragmented in a certain, okay, he's a patient that we need to consider his illness. And sometimes it fires back. He's a patient that, okay, that's carrying a heavy bill to our medical insurance bill, or he's not able to function in this position considering his illness, and then later on these people are taken out from the performing people while they are. So this is one stigma, and the other one, talking about health equity, is externally. When we just look up, outside the corner, outside the corporate, looking at the external equity for rare diseases, common chronic diseases, equity is there because most of the competitors are equally priced. But rare diseases, and this is a blind spot that started to be unveiled now and people are giving much attention. Rare diseases are very expensive in their development and research. Rare disease products and treatments are very expensive. So this pricing and access, health equity, and providing some patients with compassionate use program so that they are able to get their treatment as equal as to the chronic disease is a kind of blind spot that's now being uncovered, and some advanced healthcare systems are working on, but the low budget, less economic healthcare systems need to pay attention to.
I completely resonate with what Mr. Ahmed was telling. So I just want to, have like an extended question similar that where he considered about patients, having a chronic disease or depending on the mental issues that they have or any other physical thing that might they have. So how do you generally involve patients and communities in genuinely shaping the equity strategies when you frame your quality parameters?
See, when we speak about quality parameters, it's beyond the performance matrix. Yeah. So we also look into, for example, if I give it's a patient experience data. You look into the blind spot we have is that we don't do the data on the demographics. So when you do it on the demographics, you identify where is the gap. When it comes to community, for example, if you take it as Dubai, you need to have the local community in your advisory boards. So that is where you penetrate into the cultural sensitiveness of the land. So having those people in the advisory board will always show the inclusivity of the cultural parameters, and also having tied up with the regulatory authority. For example, the DHA. DHA does a lot of community awareness programs when it comes to healthcare equity, and we are very proud of it. And they do have those KPI matrix which speaks about the demographics and how to address it. So having tied up with those community programs also will be giving a good opportunity for an hospital or a healthcare sector to penetrate into the community awareness about the healthcare equity and catering the needs of those organizations. Thank you.
Thank you for that. So now I'm shifting the whole conversation from patient-centric to something else. A few years back, we had something called as a pandemic, which came in. After that, I think AD and BC can be like before COVID and after COVID. It's going to be AC and BC maybe in the few decades to come, maybe in the educational books and historical reference. So having COVID bringing a lot of change in terms of healthcare, how people started to perceive insurance, or during COVID when the pandemic and quarantine and all was happening, there was also a great impact for psychological health as well. And I personally feel that's where maybe the stigma increase or decrease, I can't tell that exactly, but I started realizing that many people were starting to address that as a major factor, because everybody was working from home and they did not have a work culture or an office culture change, but it was all merged together, and the whole world, not just Asia or Europe or America, the whole world went into a whole different zone. So in that aspect, what do you think, Claudia? So any specific need that you really realized that after COVID this has changed, or you felt this was much needed? Is it happening, or is it yet in the process, or still unidentified?
Okay. So I would like to answer this question as a psychotherapist, because I think, I'm wearing these two hats. COVID was the toughest time for psychotherapists. Why? People felt like everything that felt safe is now unsafe. And believe it or not, lots of, especially young people, so people who were like in their teenage years, while COVID suffer like hell still, because they feel, I missed the best time of my life. When other young people go out, dance, have fun, they stayed with their parents in a lockdown situation. Just imagine how we would have felt. So this is what happens, or eating disorders. We have lots of them because people focused only on social media. We have this comparison piece in there in a way that, oh my God, she's so much more beautiful. Maybe I should lose weight. So all these things. And I can tell you as a psychotherapist, I still handle the post-COVID in my practice, because it's still there and we can't negotiate that. And I feel that during the pandemic, people functioned. Also in the corporate world, we functioned. But now we know it's more like over, and now the exhaustion comes. And it's really there. And lots of high-level managers just said, well, I feel burnout. I know the pandemic is over, but it feels like now I realize what happened. You know what I mean? So it comes over the time.
So, Amit, I just want to know, if there is one policy that you could bring in into the pharma industry, what would that be to have better equity, health equity?
It should be external, of course, being responsible for health equity. And I cannot say responsible, but we are taking responsibility in shaping the healthcare system. So health equity shouldn't come on the expense of P&Ls and of corporates as well, because businesses are not charity. However, as I mentioned, there should be KPIs for health equity internally and externally while not impacting businesses. While doing so, as businesses, we should encourage health equity in the policies of the health systems and the ministries of health, as I said, and compromising our margins, our profits, in order to reach more patients and implementing the health equity. Yes, there are some no-go signals in health equity that we cannot provide, but as much as possible, we should utilize every opportunity to reach more patients and to provide what we are claiming to do, which is actually being done. And actually, another part is, and which is actually, I'm very happy to work in an organization that does, providing underrepresented populations and fragments. Many of our products that we're providing to our region are actually not our products. They are products of multinational companies who usually prioritize the US, Europe, and Japan, and underrepresented regions and populations are our region, our Middle East and North Africa. We are working in this domain to bridge this access gap. Yes, it's very tough even to take it further level with healthcare systems that are actually very new to these innovations, and they are very new to these budgets that were not expected to impact or to hit their budgets. And here comes our role with our partners in Europe and US, is that we need to access more patients. We need to provide what we are meant to provide with the minimum margins that any corporate can do. But this will, in return, will provide later on more access, more patients, so this will upscale the business. So on the expense sometimes of businesses, we put in our P&Ls patient access programs. It's part of our responsibilities, and actually later on it will reflect to part of our profits that we are all as businesses looking for. But it shouldn't be underrepresented, and it shouldn't go unseen.
Thank you. So just due to paucity of time, I would like to ask one last question to Dr. Pranita. According to you, how do you measure health equity within quality framework, and what are the major indicators that matters the most?
Some part of this question I have answered before. It speaks about the KPI performance matrix, but it is a data-driven approach. Also, I want to add one of thing which flashed me now, that to have an ethical committee in every hospital sector, which also represents the inclusivity of every patient, what the care needs, and also it gives the platform. Now we speak about healthcare equity. If it is not been implemented, there should be a board which speaks about it or addresses the concerns of the patient, and this is the committee which also talks about addressing such issues. See, healthcare equity is beyond any performance matrix. We do implemented this healthcare equity in the policies, organization standards, having protocols, but also giving a platform for a patient where he can voice against the concerns, and addressing also matters. So this also should be considered in the quality framework, where health equity is not just an option. It should be equal measured along with the safety of the patient.
Thank you, Dr. Pranita. So if I have to sum this whole thing up, not specifying to any individual or peculiar topic, on the whole, it is more about nothing can be done with system alone. Let it be health equity or any policy change or anything. It should be a collective, emotional, something that is related to all the emotions, which should be put together with all, keeping every factors of aspect in life, which actually brings out a collective change in the community. That's what I completely realize out of it. And as I said, strong leadership is something that can put up everything into action, because various levels, actionable should be there, and somebody who has to follow up with that, to take the responsibility to put it into action, comes with strong leadership. And it's a collective responsibility of every human involved in it to do their part correct, so as a whole the outcome becomes best and favorable for everybody involved in them. So thank you so much for being wonderful panelists. I know today equity comes into play when the time paucity came in, and we still stuck to the time. I think we're not going beyond that. Do we have any questions from the audiences, please?
Check 1 2 3. Check. Check. All right. Thank you so much. A wonderful panel and a great moderator as well, following the time guidelines. Thank you so much for that. Any questions in the crowd, please? Yes, please.
Hi. Am I audible? Thank you so much, right? I just have one quick question. So
what are the current major gaps and associated risk in the healthcare equity that we are currently seeing? And how are we evolving? And what potential growth are we working towards for the future, right? If you could just touch base a little around that, I think that will be great.
Which industries?
Actually, a similar question, Dr. Amin. Mr. Ahmed just addressed one. So do you have anything specific either in terms of quality or pharma or psychology? So
I'm just trying to relate how this can work in terms of technology as well, right? Because that's the major scale that I'm looking at. So how is that evolving?
I would like to address that because see, when I spoke about most of the blind spot which we are addressing now, that is the barriers which I would address, is having the data cut into demographics. Now, having the technologies embedded, for example, RLDetics, yeah? So this type of, any of the AI tools or any of the technologies which gives you the live dashboards, so which will segregate the data into the needs, what you want to see. Yeah, that is something which healthcare has to implement, start looking at it. And it has been in my organization recently, and it gives completely new perspective of looking at the data. So that is what I would say, that the technology implementation which will add value when it is speaking about addressing the health equity.
Can I add to this, please? Another dimension that's coming into therapeutics is the personalized treatment. It's usually being addressed through DNA testing and whole genome sequencing, so that you can expect, and anyone in this room can expect, what kind of diseases they might expect and how to avoid. And personalized medicine as well. What kind of disease is anyone experiencing and how to treat and how to prevent as early as possible? So this is kind of AI that has been integrated in many therapy areas and now being implemented on a country level. UAE is one of the leading countries to implement this to their locals by having the genome mapping and creating personalized medicine to every single citizen, which is actually impressive. Saudi is coming on the way. So this is a kind of AI intervention in health equity.
I have a follow-up question, if I may. So with the data, obviously, we do a lot of predictive models, right, to identify what is the future of healthcare looking like for an individual. So from a technical standpoint, what do you think are the key complications an organization should look at, right? Because playing with data is highly critical. So any, I would say, checkpoints for us that can probably validate this, or we need to be extremely careful? Anything from the experts?
Okay. Equity is a subjective word. Bringing it to an objective context is something like compliance and having rules for this. I suggest, just a suggestion, and I think this will be the most comprehensive, is having third-party assessing health equity, not just the organization itself.
Yeah. Got it. Thank you so much.
First of all, thank you very much for the very insightful discussion. Mine is not a question, but it's more like a consideration. So I'm coming from a corporate world, and what I can see now is that we do have KPIs around gender diversity, around really neurodiversity, trying to bridge the gap and try to address some of those. But in reality, what I can see in a practical way is that they seem like more badges that a company wear. But in reality, little is done for people going through key events of their life, like dealing with grief, for example, coming back from maternity leave. So the fear of missing out, IVF, all those kind of women's health issues, they're often overlooked. So what we could do to improve the conversation with the companies as well. That's a very broad question. But
I take this. Okay, I would like to take this. I've been 25 years in the corporate world, so I know how it feels. I don't have this super advice here, but what helped me a lot is to give the management the opportunity to be aware and to speak up. Because if we don't speak up as women, nothing will change. And I know sometimes it's a tough one because there is something somewhere here, which is called fear. Fear of losing the job, fear of not being promoted, whatever. But I just feel if you act based on your values, and if you in a way refer to the values the company is putting on the walls when you go up with your elevator, then this is the first step. Sometimes it will change, sometimes it won't. The question I ask myself at the end is, do my values correspond with the company I'm in? And as long as you can say yes, I would say it's the best choice to do. If you say no, it might be a good moment to just reconsider.
Yeah. What I've seen is the stigma around women, like they're perceived as sick, as like weak, and especially in male-dominated kind of environment.
Yeah.
So they are really, really fearing to speak up this kind of issues.
Speak up, and see your value as a leader, as a woman, and just, make space, be visible in the meeting room, just give your opinion, and don't be shy. I started with Microsoft, there was like 90% male in the room. It was pretty hard to just speak up. But and I would like to put the bridge on the mind work, if we know that we are if we know that we have something to say, then we have a different energy, and then there is a better opportunity that we are seen in the meeting board or whatever.
Thank you.
Yes, please.
Thank you so much, panelists. It was a great conversation. Corlin, I really appreciate after COVID, before COVID, but my question stands there. Have the metrics changed in terms of whether it's resilience, in terms of acceptance and health equity before COVID and after COVID? And looking at it from a leadership standpoint, how does leaders kind of really ensure that they're incorporating those changes? Someone who was resilient and was able to work 9 hours in office today may not want to work for 9 hours post-COVID, right? So how does a leader be very, what was good earlier, it may not be good now. So how does those dynamics also come into the picture, and how can leaders or even individuals be more focused on it from their own point of view, and they can come up, and how does the entire thing really roll forward?
Actually, you answered your same question, because I personally believe it comes from within. Yes. And just as you said, you say before COVID, people were working for 9 hours. Do you really think people were working for 9 hours? I would say no. They were in a place for 9 hours. They were outside home for 9 hours. But trust me, I don't know how many people will resonate here. People who actually do work from home work more. Correct. Because I'll tell you why. When you go to office, you have a set time. For example, you have to leave home by 8 o'clock. You get ready by 7. 9 o'clock, you go to office. You have your break, coffee break, tea break, etc., etc. Imagine being at home for both the genders. I'm putting it very neutrally. You don't take the time for yourself to groom. How many people just got out of the bed, just wash your face, open your laptop, and just sit? So I feel that particular thing also passively impacts the psychological health, because I am a person who will love to go out, see new people, just get the air on my face or something like that. The preparation, like for the next day, what dress I have to wear, how do I have to go, what is the meeting, what is the schedule. Now it's like this. I can finish one meeting at 9:59 and I can log into the next 10 o'clock, or maybe even parallelly. That is something which has to come from within. And today, even when offices at a point have asked people to come back, employees are refusing. They are getting settled to something less. On contrary, there are offices which also do not want their employees to come, because their additional cost heads are more in terms of electricity or whatever your data analyst or finance analyst gives them. On paper, they save millions of dollars at least per year, and they are like that. So anything and everything comes from an ethical perspective is what I genuinely feel, be it in terms of technology or in terms of psychological health. Because imagine, there's an advanced health that's come up maybe after COVID or before COVID. The company who patent has to have that ethics for them to make it generic or that. So as he said, business is not charity, but it need not to be luxury as well. So it's a balance. It is about striking a balance. That's one thing. And coming from within, to answer her question as well, when she said there is a stigma around women in general, of course it's changing. But I don't know why everywhere in every culture across the years, women has been the most multifaceted person, and that's both the pro and the con for being a woman. So.
So do you agree that the equity does not only a leadership responsibility?
Yes, it is both. It's leadership responsibility, also a collective responsibility. Imagine a leader puts in a policy, or he can only say this can change. Imagine it comes from a CEO of the company or the head of the company. Imagine the third level, the down level employee wants to still make something corrupt, he can still do it. Or it's vice versa. Even if the head, the CEO or whoever wants to make it very strict or not being so equal to everybody and fair enough, still the downliner can make an impact. Not the complete impact, but he can still make an impact. So it's a pivot, it's something in the center, also should go around. So it's both. You cannot compromise one for the other.
Thank you so much.
Thank you.
Thank you.
Thank you so much.
Thank you so much.
So we hope to have a future healthcare soon, which is completely non-negotiable to individuals, and the access is made universal in every aspect. Thank you so much for being a wonderful panel, and thank you so much everyone for being a wonderful audience right in the morning. Thank you.
Thank you so much once again. A great panel and true eye-opening discussions we had. I hope finally we all have snoozed out and had that coffee with a great discussion.